Hello everyone, welcome back. Today I'll be covering shock, especially hypovolemic and septic shock, a part 2 video. Started off with causes of shock, types of shock, hypovolemic shock, clinical signs of acute hemorrhagic shock, complication, SIRS, systemic inflammatory response syndrome, septic shock, the management. Now let's get started. The causes of shock: severe or sudden blood loss, large drop in body fluids, myocardial infarction, major infection, high spinal cord injuries, anaphylaxis, extreme heat or cold. Types of shock: 1. Hypovolemic shock, whether hemorrhagic or non-hemorrhagic shock. 2. Cardiogenic shock. 3. Septic shock. 4. Neurogenic shock. 5. Anaphylactic shock. In hypovolemic shock, there is decrease in circulating fluid volume. It can be caused by hemorrhage, diarrhea, vomiting, dehydration, burns, etc. When the compensatory mechanisms are no longer effective, cardiac function deteriorates further, worsening the tissue oxygen delivery. Blood loss in excess of 40% for over 2 hours may result in disengaging inflammatory mediator response at a systemic level. The relationship of bleeding volume to cardiac output and arterial pressure, further illustrated with the figure. The figure will show the approximate effects on both the cardiac output and arterial pressure of removing the blood from the circulatory system over a period of about 30 minutes. About 10% of the total blood volume can be removed, with almost no effect on either the arterial pressure or the cardiac output. But greater blood loss usually diminish the cardiac output first, then later the arterial pressure, both of which fall to zero when about 35 to 45% of the total blood volume has been removed. This figure shows the effect of hemorrhage on cardiac output and arterial pressure. On the left hand side, percentage of normal, and y the percentage of total blood removed. Again, if 10% of total blood volume, there is no effect on the arterial pressure or cardiac output, but greater blood loss will diminish the cardiac output first, then both will fall to zero when about 35 to 45% of total blood volume has been removed. Clinical signs of acute hemorrhagic shock based on percentage of blood loss and the clinical sign. If less than 15% of blood loss, there will be slightly increase in the heart rate. If 15 to 30% of blood loss, there will be an increase in heart rate, increase in diastolic blood pressure, prolonged capillary refill. Around 30 to 50% of blood loss, the above findings plus hypotension, confusion, acidosis, decreased urine output. If more than 50% blood loss, there will be a refractory hypotension, refractory acidosis, death. For complication, coagulopathies may occur in severe hemorrhage. Fluid resuscitation, while necessary, may exacerbate the coagulopathies. This is due to dilution and consumption coagulopathy that is provoked by the inflammatory mediators action. Sepsis and multiple organ failure occur days after acute hemorrhagic shock that is not addressed properly in the initial stage of resuscitation. Remember the golden hour? Death is a possible complication. For SIRS, Systemic Inflammatory Response Syndrome, the causes is infection, either bacteria, virus, fungal, parasites, trauma, burns, acute pancreatitis, and others. Remember the definition of SIRS? It must fulfill 2 out of 4 criteria. Among them is temperature more than 38 degree or less than 36 degrees Celsius. Tachycardia more than 90 beats per minute. Respiratory rate RR, tachypnea more than 20 per minute or less than 32 per minute with hypocapnia. The total white blood cell count, leukocytosis, is more than 12,000 or leukopenia less than 4,000. The commonest organism in SIRS is gram-negative that release lipopolysaccharide or endotoxins that activate the cytokines. Example, interleukin-1, tumor necrosis factor. For tissue trauma, interleukin-6 activate complement, coagulation, and kinin systems are affected. For central nervous system, usually patient has fever, anorexia. In the heart, there is myocardial depression. The vessel will have a capillary leak, vasodilate. In the lungs, capillary leak, VQ mismatch, microthrombi, pulmonary hypertension. For renal, there is an acute renal failure. For bone, there is a resorption. Liver is aminotransferase bilirubin acute phase protein derangement. For glucose, there will be an insulin resistance. Adipose tissue lipolysis. White blood cell count, there will be an increase in premature white blood cell, reduced white blood cell in severe sepsis. This is an important slide. Septic shock definition. Sepsis is SIRS with a documented infection. Septic shock, sepsis associated with hypotension where the systolic blood pressure is less than 90 mm mercury and signs of hypoperfusion. Severe sepsis is sepsis with one or more organ failure. Please take note. Septic shock due to gram-negative and/or gram-positive bacteria, viral and fungal infection. High output failure, we call it a warm shock. Patient will have fever, tachycardia, tachypnea, leukocytosis, inadequate oxygen extraction with high SvO2, metabolic acidosis. In cold shock, atypical presentation in immunocompromised patient. Example in diabetes, liver cirrhosis, immunosuppressive patient on steroid, chemotherapy, etc. This is due to blunted inflammatory response. Septic shock in trauma patient develops 2 to 5 days after injury occurs. Carries a poor prognosis. Assess for penetrating abdominal injuries, signs of infection, whether it's warm, pink skin or dry, elevated body temperature, tachycardia, white pulse pressure. Evaluation of shock. Internal or external hemorrhage can cause hypovolemic shock. Please determine the amount of blood loss and the duration of blood loss. That means the time of injury. Whether patient has underlying cardiac problems that lead to cardiogenic shock. Sepsis condition, septicemic shock, trauma to the spinal cord, we call it a spinal shock. Contact with non-allergic substance is anaphylactic shock. For signs of shock: cold, clammy and pale skin, rapid, quick, thready pulse, shallow and rapid breathing, oliguria, reduction in MAP, mean arterial pressure, cyanosis, loss of consciousness. Level of consciousness assessed and record based on Glasgow's Coma Scale, GCS, where the patient is alert, verbal response to stimuli, pain response to stimuli, unresponsive to any stimuli. Early signs of shock in non-complicated patient must have high index of suspicion in patient who has a minimum tachycardia. No measurable changes occur in blood pressure. Pulse pressure is potentially very useful. For monitoring, continuous ECG monitoring, pulse oximetry, non-invasive measurement of systolic blood pressure, urinary output, use a Foley catheter to record a IO chart. Core temperature, hemoglobin for hypovolemic shock and platelet that cause DIVC, blood urea and serum electrolytes and creatinine for the renal function, coagulation profile to see any consumptive coagulopathy. For invasive monitoring, essential in the definitive treatment, check for direct arterial pressure, central venous pressure, cardiac output. The treatment of shock. The aim is to increase tissue perfusion and oxygenation status by maintain airway, control bleeding, has a baseline vital signs monitoring, improve level of consciousness of patient. This can be done by positioning, ABCD approach, fluid therapy, drug therapy, keep patient in the normal temperature, to prevent hypothermia and minimize the effect of shock. Ongoing assessment every 10 to 15 minutes. Specific measures. Hypovolemia, blood transfusion. Electrolyte or acid-base imbalance. Correct the underlying cause and correct the imbalance. Sepsis, role of antibiotics. Steroid is debatable. Anaphylactic shock, adrenaline. Yay, we have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.